Good evening, everyone. My name is Alpesh Patel. I want to thank everybody for their time tonight, and I'm really honored to be a part of this wonderful symposium. These are my disclosures. There's nothing related to the conversation here other than the fact that I am a consultant for a number of professional and collegiate level athletic teams. I think there's three keys I'd like people to leave with today. First is that we agree upon the definitions and qualifiers that go into the discussion of cervical non-union. Second, that we define a strategy for the clinical interpretation of patients with a pseudoarthrosis. And third, that we leave accepting that there are both strengths and weaknesses in our decision-making process, especially in a setting of such uncertainty as we see in this case here. Well, we've already heard from the speakers tonight about the profound impact that cervical spine disease can have on the lives of our patients. And we also know from experience and from the literature that anterior cervical fusion, one level particularly, can have a very good return to play rate. And just as important as getting these athletes back to play, their performance generally stays very stable. So it's a highly successful operation for professional athletes. In our literature review, we demonstrated that one level fusion, there was no contraindication based on the literature. However, pseudarthrosis, which we're talking about right here, came around as a relative contraindication based upon our systematic review. Well, what do we know about pseudarthrosis? Well, in the general population, we know that it's related possibly to age, maybe, and also the number of levels performed. There's other possible factors, host factors, metabolic disease, bone health, smoking status. There's also surgeon technique, both with regards to disc and end plate preparation, but also the grafts that we choose and the implants that we use. Well, let's hone in on one level ACDF. If you look at the literature, it's widely variable, the reported rates of non-union, anywhere from 3 to 7% in level 3 or level 4 studies. But if we look at the FDA IDE studies for disc replacement, we see pseudoarthrosis rates being reported somewhere between 4.5% up to about 11.5%. So they do happen, right? We also know that symptoms vary. We know that many patients, about a third, will have no symptoms whatsoever. However, others may develop neck pain, radicular pain, or other neurological symptoms consistent with a clinically relevant pseudoarthrosis. But we have to stop for a second. We're talking about general population evidence, and now we're talking about athletes. And we have to ask ourselves, is this a fair comparison? Are we comparing apples to apples, or might we be having an unequal comparison? And I think the literature would suggest that athletes develop cervical conditions differently than the general population, and we need to think about them differently. For example, what are unique risks? Well, there's the potential risk that we'd worry about of catastrophic failure after a pseudoarthrosis, right? Fracture, some acute radiculopathy, acute spinal cord injury. No, that's not something that any of us have seen, or certainly has not been reported. However, it is a potential theoretical concern and one that we have to weigh. More commonly, the more common situation is that of neck pain, persistent or chronic numbness or weakness, radiographic progression from intact instrumentation to failed instrumentation. And then in the long run, with a number of athletes, we worry about the potential for chronic disability. And how might our decision to return somebody who has no symptoms to play lead to the potential for chronic disability, even if we can't link it up one-to-one, right? The fact that we release someone back to play, they develop chronic disability, I think that's a concerning factor. So we have to accept that in this setting, pseudoarthrosis in athletes, we're working without a true north. We don't have a lot of information, but we're used to doing that, right? We rely upon clinical interpretation. So the answer really here is that it depends on the symptoms, depends on the examination, depends on the primary clinical diagnosis, radiculopathy versus myelopathy, depends on the radiographs. Certainly static radiographs showing implant or construct failures would prohibit us from thinking about returning to play. Dynamic radiographs matter, right? When there's motion across a non-union site, whatever criteria you might want to use, that also should prohibit us from returning to play. And then these settings of stable pseudoarthrosis, like we're talking about here today, where the implants are intact, but we know there's not a solid fusion there. We also have to consider the sport and the position. There are certainly high risk and low risk sports. Football in this setting, collision sports are one that we want to think twice about. And we ultimately have to draw a line in the sand and make a decision on which patients are going to be okay to return to play, and as in this case here tonight, which patients are not okay to return to play. The other aspect of this that we have to consider is the interpretation side, right? There's a real big impact to the decisions that we make. We affect a lot of constituents, the patients, the players, families, their agents, but we also have an influence and an effect on the team management. And we have to think about the potential impact, both legally and contractually, that our decisions may make for both of these elements, right? And so these constituents create externalities in our decision making. And even the best of us are oftentimes stuck in the middle between a lot of competing interests. And that may affect, in some way, our decision making process. We are human beings, after all. We are prone to bias. And in this setting of a lack of clear-cut information, there's a number of biases that we oftentimes fall back on. And I think you may hear many of these tonight. Availability bias, we think about the most recent patient or a recent patient. Hindsight bias, so everything in hindsight we have clarity on. There's certainly curse of expertise, where we know so much that we think we know everything, but we really don't. And then lastly, there's groupthink. Well, when we're not really sure what to do, what are most people going to recommend in this setting? Now, those are biases we can't ignore. But if we're aware of them, we can try to work around them and make sure they're not influencing us too much. So in the setting of a pseudoarthrosis in the athlete, it's really a setting of uncertainty. I think we're obligated to start with a hard no, okay? Weigh the risks, weigh the benefits, look for those externalities that might be influencing decision-making in one way or the other. And I guess almost always you're gonna end up with the answer being no. And in the setting of a non-union that's a one-level situation with all this uncertainty, why not go ahead and revise it, get it to heal solidly, and then this athlete can return to play without any of the concerns that we've just talked about. Thank you very much for your time tonight. Good evening.